Welcome to A Taste of Medicine. I'm Michael Lawson, a hospitalist physician in Minneapolis. I wanted to talk about all things Delta variant. What is it? Is it worse than the other variants? And if so, how? Do the vaccines work against it or not? And how is this going to play out in the United States over the next few months? Let's get after it. Hey everyone, my name is Michael Lawson. I am a board-certified internal medicine physician working as a hospitalist in Minneapolis, Minnesota. My hospital is Hennepin Healthcare. It is a level 1 trauma safety net hospital. It's been several months since my last video, and the big reason for that was I didn't have a lot to talk about. But that has certainly changed recently, and everyone is talking about the Delta variant. All right, so we have a couple objectives that I want to hit over this video. Number one, just to talk about why variants happen and why most aren't a big deal, but some are a huge deal, like the Delta. Number two, why transmissibility, how easy the virus spreads from person to person, is not necessarily linked with virulence, how dangerous it is to a given person who contracts it. Number three, the evidence that the vaccines, despite this new dangerous variant, still work really well at keeping us safe, keeping us out of the hospital, and most importantly, keeping us alive. And finally, how I anticipate that this is going to play out in the United States over the next few months. So first, why do variants happen? Why do mutations happen? So variants happen due to errors in transcription. Errors of transferring the genetic code into proteins or new viruses. Most of those variations are evolutionarily dead ends. They don't work. They either aren't going to transmit as well or aren't going to infect a host, and so that's a good thing. The problem are these very rare exceptions where these mutations cause variants which are much better at spreading from person to person, or potentially much more likely to kill people. Reuters last year published this really nice review piece on how the novel coronavirus has evolved over 2020. There are a couple of things I wanted to highlight about this article. The first is this graphic. So this was worldwide looking at strains beginning in January, ending in November of 2020. As you can see, the original Wuhan strain was effectively gone by summer. So this virus has continued to mutate, as all viruses do, has continued to mutate consistently over that time. And one thing to note is that GV is denoted as the UK variant, now called the Alpha variant, also previously known as B117. In this graph, we see how on each continent it was significantly different about which strains were most prevalent at which times. One of the complicating factors of this is that terms change over time. Initially, when these variants of concern began to become noticed, they were denoted by where they were first found. That's why we had the UK variant, the South African variant, and the Brazilian variant. The problem is that those variants will spread to other parts of the world, and pretty quickly the UK variant was the predominant variant in many of these other countries. And so the scientific community took a step back and said, the simplest way is to just name them Greek letters. It's our Alpha, formerly known as the UK variant, or B117, Beta, the South African variant, or B1351, Gamma, the Brazilian variant, P1, that's easier, and then finally Delta. This was originally described in India and has the lineage B1617-2. That allows us to talk about these variants with less confusion. But for right now, the UK variant is Alpha and Delta is coming from India. So the CDC has been tracking these variants pretty closely since April. The first documented case of the UK variant in the United States was December 29th in Colorado. By mid-January, there were 70-some documented cases. And by early May, it was causing 70% of all new COVID infections. It went from one case December 29th to 70% of all new COVID infections in a matter of 4 months. And we've seen the same pattern with the Delta variant. In the end of April in the United States, it was responsible for about 1 in every 200 new COVID infections. And as of now, it's causing more than 80% of all new COVID infections. It has effectively displaced the Alpha variant, UK, and all other variants as the preeminent cause of new infections. So why is that? It's better. It's better at spreading. From the virus's perspective, a virus is successful if it spreads. That's the only thing it cares about. It doesn't care if the host lives or dies. It just wins. From an evolutionary perspective, it wins if it spreads. And so if you have a strain that is just better at spreading from person to person, it will outcompete the other strains. This is evolution in action. We see the same thing in Scotland. So Scotland, in a matter of a month, the month of May, went from effectively having 90+% of their infections caused by the Alpha variant to almost 75% of their infections being caused by Delta. So objective 2, and I've heard this from people in and outside the healthcare, in the mainstream media, and on the internet. There's a generally held idea in virology that as a specific virus gets better at spreading from person to person, its virulence, the ability for it to make you really sick or kill you, goes down. And that's because the virus just wants to propagate, wants to spread. It doesn't care. It has no moral compass about whether it kills its host or not. SARS-CoV-2, COVID-19, is different. Its incubation period is way longer than most viruses. So you can go from having no symptoms and shedding the virus without feeling bad to starting to have some symptoms to dead in a matter of 6-8 weeks. So that's a long time. From the virus's perspective, it has plenty of time to spread. There's no evolutionary pressure on that virus to become less dangerous, to become less virulent, because it has plenty of time to spread. If it spreads to 30 people and then kills you, well, in the virus's mind, it's still a success. Now, we don't know the answer with Delta variant yet, whether its virulence is higher than the UK variant or higher than the original Wuhan strain. That's going to take some time. But there is good evidence that the UK variant was more virulent than the previous Wuhan strain. One article that was published in Nature in March followed patients in England. And this study found that the absolute risk of death increased by 50% for the Alpha variant, the UK variant, compared to other strains at the time. A different article published in the British Medical Journal, also in March, found that there was about a 60% increase in mortality of the Alpha variant compared to other strains. A third study, also from England, demonstrated the same thing, a 60% increase in mortality rates. But they were able to kind of break down this really nice figure that demonstrated the older you were and the more comorbidities you had, the sicker you were, the more risk you were at. So we know that the Alpha variant was significantly better at transmitting from person to person, yet despite that, it was also more virulent. All right, objective 3, how do the vaccines stack up against it? So I've been seeing more and more articles like this one from the Boston Globe, where in Singapore, 75% of COVID infections are among vaccinated and partially vaccinated people. So unsurprisingly, you hear responses that, oh, the vaccine's going to make it more likely that you get COVID. This is where the base rate fallacy comes in. So let's talk about that. In the description below, I'm going to link 2 things specifically related to the base rate fallacy. The video does a really nice job explaining how the base rate fallacy works, as well as the blog post from your local epidemiologist. Again, does a really nice job making what seems like a really complex idea very accessible and straightforward. Okay, so if we go back to November of 2020, 100% of new infections were in unvaccinated people, because there were no vaccinated people yet. Well, as the population becomes more and more vaccinated, the pool of unvaccinated people becomes smaller and smaller. And we know from the trial data of all the vaccines that none of them are 100%. So imagine 100 people and 85 of them have been vaccinated. Now let's say that 2 people in the vaccinated group got COVID-19 and 2 people in the unvaccinated group got COVID-19. Well, you could say, well, it's 50-50. Half of new infections are in those who have been vaccinated. And if you don't sit there and look at the numbers, you could say, oh, well, the vaccine isn't protecting you. Meanwhile, the infection rate in the vaccinated patients is 2%, and those in the unvaccinated is 6 times that at 13%. So I highly encourage you to spend a couple of minutes, read the blog post, watch the video, and really get a better understanding at base rate fallacy and how some of these headlines can be really misleading. So how well do the vaccines work? Well, we got to look at the data. First up, Israel. Israel has been in the news quite a bit around COVID-19. I've talked about on my channel about what a wonderful job they did vaccinating their population so quickly back in January. And some of the reports coming out of Israel previously were saying, yeah, we're finding that Pfizer, which is the vaccine they exclusively use, was high 80s, 90-something% effective at preventing infections in the previous strain, but it's looking like it's significantly lower with Delta. As low as 60-some%, sometimes low as 40-ish%. Now that report conflicts with other reports out of England, Scotland, Canada, and the United States that are showing that the vaccines are actually pretty good at preventing infection from Delta variant. I'm going to have to do a subsequent video where I really dig in deep to the details in this, and the data is very new and hasn't necessarily been peer reviewed yet. But even the most pessimistic data, the Israel data, is still saying that it's 88% effective at preventing hospitalization and over 91% effective at preventing death. All right, well, let's say you don't trust the data, okay? For whatever reason, you don't believe it. Well, how is it playing out in the real world? If the vaccines didn't protect against infection or hospitalization or death, we would expect to see similar rates across areas of high vaccine rates and low vaccine rates. If the vaccines are doing a good job and are keeping people healthy and out of the hospital and alive, then you would expect to see the new waves hitting areas where vaccines uptake was the lowest. And that is exactly what we're seeing in the United States right now. So this article from The Atlantic goes over Missouri and what a challenge it is in parts of Missouri. At the time of this writing, in July 16th, there were 75 counties in the state of Missouri that had fewer than 30% of their population vaccinated. Some of the lowest vaccine use in the entire country. This Washington Post article does a really nice job trying to compare apples to apples. If we're trying to figure out if vaccines work, then we should be looking at infection rates in the unvaccinated and the vaccinated. So the Washington Post said, if you take out the vaccinated people of Missouri, the case rates in Missouri are as high as they were at the height of the surge back in December. But what about hospitalizations? Well, if we go to Missouri, that has one of the lowest rates of vaccination, my state of Minnesota, which is kind of in the middle to high end, and then Vermont, which has one of the highest, you see it borne out in the hospitalization rates. The hospitalization rates in Missouri are as bad as they were back in January and continuing to climb amongst the unvaccinated. You see hospitalization rates in Minnesota being pretty even and level throughout the summer. And in Vermont, it's negligible. So if the vaccines don't matter, then why is it that for the states with the worst vaccine rates, Missouri, Florida, Louisiana, and Arkansas, are having the highest rates and driving the vast majority of infections in the country? It's because the vaccines work. It's because they prevent infection. It's because they prevent hospitalization. And almost assuredly, they're going to prevent death. On average, SARS-CoV-2 takes several weeks to kill you. If you are going to die from the infection, it is not like a snap of the fingers. Generally, people are going to suffer in the hospital for a few weeks before their lungs just ultimately fail. So we won't have the data as far as the death rates go for weeks and maybe even months yet. But to me, it is a foregone conclusion based on infection rates and hospitalization rates. Deaths will unfortunately follow. And as far as where the Delta variant is most prevalent, it's everywhere. As you can see on this CDC website, it is causing well over 80% of all infections in almost every single part of the country. Here's some graphs from the Mayo Clinic's website. You see on the left, percentage of overall state populations vaccinated in green, with darker green being higher rates of vaccine uptake, yellow-green being low. In Minnesota's data, we see a couple of things. The elderly population over 65, we have over 90% of our population fully vaccinated. It drops off with age. So the younger you are, the less likely you are to have been vaccinated. In the Atlantic articles that were referenced earlier, there's a lot of anecdotal evidence that they are seeing younger patients in their 30s and 40s who are unvaccinated in the ICU, in the hospital, at rates that they didn't see before. I would expect that we are going to see risk of death, risk of hospitalization be significantly higher in younger populations than what we were talking about last summer, last fall. States, counties, cities that have very low rates of vaccination are going to get hit super hard. I would love to be able to convince someone that they should go get vaccinated. But realistically, that's not going to happen. So, for what it's worth, I really hope you're vaccinated. I would really encourage you, if you got just one of the shots from Pfizer and Moderna, really get number 2. There's good data out of UK that second shot is really important at protecting yourself against the Delta variant. All right, we'll leave it there for this time. Thank you for your attention. Thanks for joining me. Hopefully this was helpful, although almost assuredly not very inspiring. And stay safe out there. We'll see you next time.